Hello, this is Dr. Philip May. I'm going to be speaking to you today about the 7 types of osteoporosis encountered in adults with developmental disabilities. Before we get started, I'm going to review with you the World Health Organization criteria for osteopenia and osteoporosis. Normal T-score is greater than or equal to -1 standard deviation. So if you had a T-score of -1, that would be normal, but anything less than that is low. Osteopenia is classified as a T-score of -1.1 to -2.5 standard deviations below the mean. Osteoporosis is less than or equal to -2.5 standard deviations below the mean, and severe osteoporosis is less than or equal to -2.5 standard deviations below the mean with a history of a fragility fracture. The NIH convened in 2000 to develop a new definition of osteoporosis, and the NIH Consensus Conference definition of osteoporosis is as follows. First, osteoporosis is defined as a skeletal disorder characterized by compromised bone strength, predisposing to an increased risk of fracture. Bone strength reflects the integration of 2 main features, bone density and bone quality. Bone density is expressed as grams of mineral per area or volume, and in any given individual is determined by peak bone mass and the amount of bone loss. Bone quality refers to architecture, turnover, damage accumulation, and mineralization. So the bottom line here is that osteoporosis is not defined strictly by the T-score, but it is a measure of bone strength that consists of bone density and bone quality. And we can measure bone density and bone quality, but we can't measure bone strength directly. The types of osteoporosis encountered in adults with developmental disabilities include developmental osteoporosis. This refers to failure to attain a normal peak bone mineral density. Vitamin D calcium deficient osteoporosis, also known as osteomalacia. Aging-related osteoporosis, known as senile osteoporosis. Postmenopausal osteoporosis in women and post-andropausal osteoporosis in men. Disuse osteoporosis due to inadequate weight-bearing physical activity. And lastly, drug-induced osteoporosis, which is caused by polypharmacy for the most part. And I'm going to be going over these in more detail towards the end of the talk. To make some general statements about lifetime risk of fracture in the general population, in women 40%, men 13%. Those figures are not known for adults with developmental disabilities, but I would predict that men and women both have a high incidence of lifetime fracture, and it'd be slightly higher in men than women in people with developmental disabilities. Risk factors for osteoporosis include those that you can do nothing about, the non-modifiable, or those that you can change. Things that you have no influence over, the age, genetics, your gender, your race, but there are things you can change, and that's the exercise, your diet, calcium, exposure to sun, and smoking and alcohol abuse. Now the Fraks test has become popular. It's probably not of much use in people with developmental disabilities, but the concept is good, and basically this is a computer program. You enter in certain risk factors, which we have listed here, and the program calculates a 10-year probability of fracture of the hip and or spine. And those risk factors include age, gender, weight, height, history of previous fracture, a parent with a hip fracture, current smoking, use of glucocorticoids, rheumatoid arthritis, secondary osteoporosis, which I'm going to be going over on the next slide, and alcohol ingestion. And you can calculate a Fraks using the bone mineral density or not. Bone turnover is also a measure of fracture risk, but this is not included in the Fraks calculation. Now, these are some of the clinical disorders associated with osteoporosis, which can lead to secondary osteoporosis. These include neuromuscular disorders, drug side effects, hypogonadism, genetic syndromes such as Down syndrome, Prader-Willi, homocystinuria, which are all associated with developmental disabilities, low intake of calcium and vitamin D, hyperparathyroidism, Cushing syndrome, pituitary failure, intestinal malabsorption or celiac disease, renal failure, renal tubular acidosis, liver failure, rheumatoid arthritis, and type 1 diabetes mellitus. Now, there's some risk factors that are especially relevant to adults with developmental disabilities, and these include polypharmacy, vitamin D, calcium deficiency, seizures, impulsive behaviors, motor dysfunction, normal ambulation. Strangely, it appears that those people with severe developmental disabilities that can ambulate normally are at greater risk for fracture. The male gender and severe cognitive dysfunction is also associated with an increased risk for fracture in people with developmental disabilities. The treatment of osteoporosis includes dietary approaches, exercise, and pharmaceuticals. Now, there's several different opinions about when a drug should be used in the treatment of osteoporosis, and the International Osteoporosis Foundation has developed recommendations, and they suggest that a pharmaceutical might be considered in postmenopausal women and men older than 50 years of age based on any of the following conditions. Number one, a history of a hip or vertebral fracture. If the person has had a fracture, then a pharmaceutical might be considered. If the T-score is in the osteoporosis range, consider a bone drug. If the T-score is not in the osteoporosis range, that is, there's osteopenia, but a Fraks test reveals a probability of a hip fracture of 3% or more, or the probability of any major osteoporosis-related fracture of 20% or more, then it's appropriate to consider a drug to treat the low bone mineral density under those circumstances. But perhaps most importantly, none of these considerations should replace good clinical judgment and patient preference. And so there may be certain circumstances that even though the patient may not meet any of these three criteria, nonetheless, if there's a reason to treat, then by all means it's appropriate to do so. Now, the international osteoporosis recommendations we just covered, the National Osteoporosis Foundation, which is from the United States, have their own indications for the use of drug treatment, and the NOF, as opposed to the IOF, suggests treatment if the T-score is less than -2, but if the patient has a T-score in the osteopenic range, and there's a family history of osteoporosis, a previous fracture, history of smoking, or a low body weight, then they would recommend consideration of a bone pharmaceutical, especially a bisphosphonate. Now, thinking about adults with developmental disability in particular, the IFCD has been struggling with this issue, and these are by no means widely discussed, but we're starting a discussion about the problem in people with developmental disabilities. So the IFCD is sort of throwing out these suggestions. If there's a history of a fracture, consider a pharmaceutical. If the T-score is in the osteopenic range, then a trial of maintaining an optimal level of vitamin D, 40 to 60 nanograms per milliliter for a year, and then seeing if that helps. That would be a reasonable approach. Another reasonable approach would be strictly if there is a osteoporosis level T-score not caused by any secondary cause, then it would be appropriate to consider a bone pharmaceutical. And if there's increased metabolic bone turnover, if there are other clinical risk factors present, for example, seizures, ataxia, impulsivity, severe cognitive dysfunction, low physical activity, or polypharmacy, one might consider using a bone drug. Also, it should be noted that pharmaceutical treatment should be monitored with serum bone turnover markers, especially P1NP and CTX, as well as bone mineral density by DEXA. And the serum 25-hydroxy vitamin D level should be optimized and maintained year-round in the 40 to 60 milliliter range before bone drugs are prescribed, and that should be continued after the person is on a bone drug. Once again, going back to the types of osteoporosis encountered in adults with developmental disabilities, there's the low peak bone mineral density syndrome, the osteomalacia, senile osteoporosis, postmenopausal, postandropausal, disuse osteoporosis, and drug-induced osteoporosis from polypharmacy. And there can be combinations. In fact, there probably are more commonly combinations of these different conditions. There is you can see a chemical reaction on the number 5 there showing that estrogen actually comes from testosterone, that testosterone is converted to estrogen. So there's loss of estrogen from men as they get older, and this could be causing the increased bone resorption seen in aging men, just as it is in women. So, but these are the different categories of bone pathophysiology that one might encounter, and using a combination of bone mineral density and bone turnover markers, you can usually categorize them into these different groups. So in summary, osteoporosis is common in people with developmental disabilities. There appear to be multiple mechanisms. There is a need for more clinical research to document frequency and effective treatments. And efficacy of treatment should always be documented with bone mineral density and or bone turnover marker determination. Thanks for listening. Again, this is Dr. Philip May. If you need to get in touch with me, send me an email to ifcd.pmay@gmail.com. Bye-bye.